Welcome, everybody. I'm Greg Roskoff, owner and developer of muscle activation techniques. And welcome. We have a lot of people here today, and we're going to talk about foot function. And so basically this, basically we have a complex structure that, I always say the foot's the first thing that hits the ground, and the rest of the body has to react to what the foot does. And so we really have to have an understanding of foot mechanics in order to understand its relationship with the total body function. I started really getting interested in the foot because I had a fractured vertebrae, and when I was 19, and literally over 25 years ago, had a lot of residual problems related to it. And next thing I know, I had patellofemoral syndrome, plantar fasciitis, SI joint dysfunction. I had one injury after another, and my body had just gone through a lot of compensatory movement patterns. And in the big picture, that's what led me to the development of MAT. But it started, actually, my whole process started when I was working at a physical therapy group, and I had a physical therapist that understood the biomechanics of movement and the interrelationships of joints and how the foot, the ankle, the knee, the hip, and the trunk, all the way to the occiput were interrelated. And one day I came in complaining how my back was bothering me, and this physical therapist, Richard Jackson, he taught classes all over the country in spine mechanics to physical therapists and mobilization techniques for spine problems. But he actually did an assessment on me, and my back was killing me, and he mobilized my big toe. And for the rest of the day, my back didn't hurt. I was literally at that point in time with, how can my big toe have anything to do with my back pain? And so that got me looking at the whole biomechanical chain. And like I said, how the foot, the ankle, the knee, the hip, the trunk, all the way to the occiput are all interrelated. And so I started seeking out specialists in every field that understood the biomechanics. And ironically, it brought me to some physical therapists, Gary Gray, who I would say is probably the king of function and functional training, functional movement. Brought me to Gary and some podiatrists that looked at foot mechanics and how the foot impacted motion up the chain. And I really started to gain an understanding of foot mechanics. But the interesting thing was that everyone that I was learning from at the time, through understanding foot mechanics, the end result was putting people in orthotics. And so I transferred, into that. Even though I was in the training and sports performance side of it, I really gained an understanding of foot mechanics. But my fix was, if somebody had abnormal foot mechanics, I would put them in orthotics. And so I had the goal to change function up the chain. My goal was, if I can change the way the foot hits the ground, then I can maybe take stress off joints and tissues up the chain that may be painful. But over time, one of the things that I realized, and a perfect woman was the example where she came into me. She was an ultra endurance runner, and she came to me with hip pain, chronic hip pain. And so I put her in orthotics, and then I would set them up on follow-up exercise programs and to tie in with this interrelated chain. And so I put her in orthotics, and her hip pain went away immediately. And so once her hip pain went away, I thought I did my job, and we were doing the exercise programs. And she came in one week and said, I don't know if this has anything to do with it, but ever since I've been in these orthotics, even though my hip pain's gone away, she goes, I can barely sleep at night because my neck hurts so bad. And I had to go back to what I heard myself saying all the time, is how the foot, the ankle, the knee, the hip, the trunk, all the way to the occiput are interrelated. And she's got neck pain all the way to the occiput. And she's got neck pain as far away from the foot as you could be. And so I was like, well, I can't ignore that fact. And so I said, let's try something. So I took her out of the orthotics, and she comes back the next week, and her neck pain's gone, but her hip pain was back. And all I realized at that point in time is all I did was redirect the stress. And it seemed to me like when I would put people in orthotics that things would change. Their pain that they came in complaining about may have gone away, but something else may have arisen. Some other dysfunction or pain issue may have arisen. And so I started looking, I wanted to look deeper into that. And at the same time, through all of this, I was developing muscle activation techniques and looking at the muscle system's role in chronic pain and injury, and recognizing through muscle activation techniques, I always say the integrated system is only as good as the function of its isolated parts. So we literally, through the principles of MAT, we look at all the isolated parts and understand that if somebody has shoulder dysfunction, that there's all these moving parts that have to be working all at the right time. Like muscles have to be able to contract and contract on demand, and functions about timing. And so when we understand the mechanics of just lifting into shoulder flexion or abduction, you understand that you have to have components of motion. You have to have spinal extension. You have to have upward rotation of the scapula. And that's all about timing, because initially the axis of motion is at the superior angle of the scapula, and then as you create tension on the acromioclavicular ligaments, the axis changes to the AC joint, and then you have your rotator cuff muscles holding the head of the humerus and the glenoid. You have all of these things that have to happen, and they have to happen at the right time. And so in that philosophy, I've always looked at that muscles move bones and muscles hold bones in proper alignment. And as long as those muscles are all firing and firing on demand, they can do their job and normal motion occurs. And so my thought was, why does this philosophy change with the feet? I mean, you have muscles that support the feet, and they come up the leg. You look at the origin insertions, the red and blue paint on this. These origins come from the leg and come down and insert, the muscles insert onto the feet. So why would we think that muscles don't have an impact in the feet and foot mechanics the same way that they impact shoulder mechanics and spinal mechanics and motion throughout the body? So I really started looking deeper at foot mechanics and muscle function with the feet, and really understanding, like I said, the integrated system is only as good as the function of its isolated parts. Now you take this complex structure, and this structure here, from the knee down, you have 28 bones and 55 articulations. And the foot has two main functions. These two main functions are to be able to, when the foot hits the ground, to be able to be a mobile adapter, to be able to absorb shock. And then at the right moment in time, as the swing leg comes through and drives you into propulsion, that foot has to be a rigid lever so that your whole body can transfer its weight over top of that rigid lever. And so a lot of things have to happen at the right time. It has to be a mobile adapter at the right time, and it has to be a rigid lever at the right time. And a mobile adapter would be a pronated foot, and a rigid lever would be a supinated foot. So basically, the foot has to be able to pronate, and it has to be able to supinate. And we know in the foot industry, when we talk about feet, pronation is like the buzzword that people have pronation problems. Well, I had someone tell me one time, is like, yeah, I went and got my feet evaluated and they told me I pronate. And I'm like, that's great, because pronation is half the gait cycle. And I hope you supinate also. And where dysfunctions occur is if you're pronating or supinating at the wrong time. And that's what we're going to kind of talk about, is understanding foot mechanics and this complex piece of machinery here, which is, like I said, the foot is the first thing that hits the ground. So the rest of the body has to react to what the foot does. And so when that foot hits the ground, there's motion occurring at multiple joints in the foot, the same way that when I said if you go into shoulder flexion or abduction, that there's motion occurring at multiple joints in the shoulder. So you have to break this complex piece of machinery down into its isolated parts also, and understand that if you can't get motion at one joint, your body will try and compensate and pick it up at another joint where it can get that motion. So the first thing about understanding foot mechanics is understanding the main joints that are involved. Even so, though I said there's 28 bones and 55 articulations, I mean, that's what allows it to be the mobile adapter and the rigid lever when the muscles are contracting and doing the right thing at the right time. But there's main joints that we can look at that muscles can function around. And those main joints, if we start from the rear foot and move to the forefoot, those main joints, the first joint is the talocrural joint. And the talocrural joint is basically the joint where the distal tibia and fibula come down into the talus and articulate with the talus. So you see here where the tibia and fibula move over the talus. So in motion, that's one of the movements that occurs in lower leg and foot mechanics. But something really interesting about that, I mean, I said we have all these muscles that come up the leg. Look at the other end of the tibia and fibula. Where does that go? To the knee. So the foot has a direct impact on knee joint function. And you think from the opposite standpoint, the femur comes down from the hip. And so basically you have the femur coming down from the hip and the tibia and fibula coming up from the leg. I always say the knee is a dumb joint. The knee is basically looking up at the hip saying, hip, you tell me what to do, and foot, you tell me what to do. And if you two don't agree, then I'm in the middle getting beat up, because you cannot impact foot mechanics and not affect knee joint mechanics. And so those are the considerations we have to have when we do make changes or we put artificial support devices, i.e. orthotics, in people's feet, is what impact is it having all the way up the chain? And so hopefully when we get done with this, you'll have a better understanding of the foot and the muscle system's role in foot mechanics and how it impacts movement all the way up the chain. But when I talked about the origin and insertions here, there's 50 muscles that attach from the knee down. That's a lot on each side of the body. There's 50 muscles that attach from the knee down. And all of those muscles have an impact on lower leg and foot mechanics. And so we have to understand those muscles. I mean, we can think anterior tib and gastroc, but when we got the peroneals, the peroneus longus, peroneus brevis, tertius, the anterior tib, the flexors of the toes, the extensors of the toes, we have the posterior tibialis. I mean, we have all of these muscles that attach, most of them attach at the lower leg and come down and also attach to the foot. So the foot is never functioning independent of the lower leg because the attachments of most of the muscles come up and attach on the lower leg. And so the key is these 50 muscles are responsible for controlling pronation and supination. So pronation, like I said earlier, is when the foot hits the ground. I mean, you have to absorb shock. And so that foot has to be this, mobile adapter to adapt to abnormal terrain and absorb shock. And so muscles function to eccentrically control pronation. When that foot hits the ground, the muscles are eccentrically controlling pronation as they eccentrically control internal rotation of the tibia and ankle dorsiflexion. And so the role of the muscles in shock absorption are to eccentrically control motion. And then those muscles are placed, as they eccentrically control motion, they are placed on a stretch. And then as the swing leg comes through and drives the rotational force, as it pronated, everything collapsed down and inward. And then as the swing leg comes through, it creates an external rotation and propulsive force that actually locks that forefoot to the rear foot. And then you have a rigid lever to propel off of. So the same muscles that eccentrically control pronation are the muscles that are concentrically creating supination. So muscle function plays a huge role in our overall function and our functional capabilities. The key is where we have dysfunction is that in that transformation from pronation to supination. If the timing's off or the muscles aren't contracting as efficiently as they're designed to contract, then the body comes in, it lands on the foot, and the muscles that can't, if they're not strong enough and active enough to be able to eccentrically control pronation, then they can't concentrically supinate. And then you have the problem of an excessive pronator. So pronation is a neuromuscular disorder. And when I started learning early on from top specialists in physical therapy and podiatry, the common theme was that if you had mobility, if you locked in a supinated position, if you invert the calcaneus, the forefoot should lock to the rear foot because that would be the position that the foot's in when you supinate. And so if you were in an open chain environment, if you evaluated somebody and you inverted, inverted their calcaneus, and this forefoot didn't lock to the rear foot, then it was considered ligament laxity. That's a structural, or I mean a passive structure issue that can't be solved through muscle function. And so the idea when somebody had that ligament laxity is that they need orthotics because of the instability in their foot. They need orthotics to help maintain that stability through the foot. And so that's, I mean, literally what I would do when I would put my thought was when I put people in orthotics, I was trying to create stability through the foot. Well, muscles move bones and muscles hold bones in proper alignment. When I say that, that means muscles are what provide stability through the foot. And as I created MAT and started looking at all the muscles in the foot, we can actually test every muscle in the foot. I actually went through, and early on in my career, I went through and evaluated people's foot mechanics. And what I thought was a ligament laxity issue, after I got muscles activated and able to contract and contract on demand, when I invert the forefoot, what appeared to be a ligament laxity issue was no longer a ligament laxity issue because the muscles were now doing their job to hold the bones in proper alignment. And when I supinated the forefoot, the rear foot, the forefoot would lock to the rear foot. So it proved to me, or it was my first eye opener, that muscles control foot mechanics. And so the muscles have to eccentrically control pronation, and concentrically through the storage of elastic energy in the recoil, they concentrically create supination. So started looking at the muscle function and started seeing changes. And I can tell you over the last 25 years, I've taken more people out of orthotics and been able to improve their foot mechanics by improving muscle function. And so we'll show an example here in a little bit, but it's understanding. The first thing is I said there's 50 muscles that cross the axis that attach below the knee joint. But it's first understanding all these joints. I started with the talocrural joint. All these joints have to have independent motion, or the capability to move through their independent motion, which is what their axis dictates. And if they can't, then the body has to compensate for that lack of motion. And so if we understand the first movement, like I said, was a joint is the talocrural joint. The next joint is the subtalar joint. So the talocrural joint and the subtalar joint make up the rear foot. And so this talocrural joint, based on its axis of motion, they're basically horizontal that comes through the medial to lateral malleolus. Based on its axis, the dominant motion that occurs at the talocrural joint is ankle dorsiflexion. And the subtalar joint, with that axis coming more oblique to them from the calcaneus through the talus, the motion that occurs there is transverse and frontal plane motion. And based on the position of the axis, there's almost equal amounts of transverse and frontal plane motion in the subtalar joint. So if you think of transverse plane motion as basically adduction and abduction through the terminology of foot mechanics, and frontal plane motion is inversion and eversion. And so in the rear foot, through the talocrural joint and the subtalar joint, you have a large amount of motion in all three planes. You have a significant amount of sagittal plane motion through the talocrural joint, and then you have a significant amount of frontal, or equal amounts of frontal and transverse plane motion through the subtalar joint. So significant amounts of motion in all three planes. And then on the midfoot, or the midfoot to forefoot, is made up of the mid-tarsal joints. And the mid-tarsal joints are made up with your talonavicular joint and your calcaneal cuboid. So it's basically moving forward. You have the subtalar joint, which the talus is the common denominator between the mid-tarsal and the subtalar joint. But basically, you have two different axes. One, the longitudinal axis, is through your talonavicular joint, and then the oblique axis, which is more oblique, runs through your calcaneal cuboid joint. And so between those two axes, you have combined motion. The longitudinal axis is more horizontal, so that provides motion in the frontal plane, which gives you inversion and eversion in the forefoot. And the oblique axis provides sagittal and transverse plane motion, which gives you plantar flexion and adduction, or dorsiflexion and abduction, combined motions about that axis. So again, like the rear foot, you have equal amounts of motion in all, or significant amounts of motion in all three planes. So then we have to understand foot mechanics as it relates to function. If you were to stand and if you're sitting or standing, I want you to just think about if you invert your foot in the open chain, if you have your foot and you just invert your foot, you have a combination of plantar flexion, adduction, and inversion throughout the whole foot. And if you evert it, if you turn it out, you have a combination of dorsiflexion, abduction, and eversion. So those are combined motions that occur about the axis of the foot. But when I just talked about foot mechanics, I talked about the different axes between the forefoot and the rear foot. When you're in the open chain, the forefoot and the rear foot move in one direction. They move together. When the foot's on the ground, as soon as that foot hits the ground pushes the foot back up. So basically the ground comes, hits the foot, it becomes fixed to the ground. And see how when this foot hits the ground, the forefoot is actually getting pushed up. So the forefoot is getting pushed up into dorsiflexion, abduction, eversion as the leg and body weight comes down in the opposite direction. So the rear foot and the forefoot move in opposite directions when you're on weight bearing activity. So in open chain activity, the forefoot and the rear foot move together. When that foot hits the ground and body weight comes crashing down on that fixed forefoot, the rear foot plantar flexes, adduction, and everts as the forefoot gets pushed up into dorsiflexion, abduction, and inversion. And so the forefoot and the rear foot move in opposite directions in weight-bearing activity. And that's where muscle function comes in. When the forefoot and the rear foot move in opposite directions, those muscles that eccentrically control pronation are being placed on a stretch. When I turn my foot in the open chain and I turn my rear foot and forefoot together, the muscles through the arch are not being placed on a stretch. They're moving independent. They're moving together, the forefoot and the rear foot. So there's nothing that's going to create any type of stretch on those muscles in the open chain. But in the closed chain, when the foot's on the ground, the forefoot gets pushed up and out while the rear foot comes crashing down and in with the leg. And that creates a stretch on all the muscles of the arch, and those muscles that come and support the arch run all the way up on the leg. And they're in the same way, they're eccentrically controlling internal rotation of the tibia and dorsiflexion at the talocrural joint. They're eccentrically controlling motion at the leg while they're eccentrically controlling motion through the arch. And so the muscles are placed on a stretch so they can store elastic energy. And then again, where I said the swing leg comes through, drives an external rotation force, and all of a sudden that stored energy is released. So the forefoot and the rear foot move in opposite directions when the foot's on the ground, which is completely different than when the foot's off the ground. And that's what allows us to, allows muscles to be so dominant in our function. And so again, you have all these muscles that run up the leg. We have 50 muscles from the knee down. And that's pretty significant. I mean, when in muscle activation techniques, we have the ability to test and treat 276 muscles on each side of the body. 50 of those muscles are below the knee. So that's pretty impactful. So we can't minimize the fact that these muscles have a significant impact on overall total body function. And so we think about movement and we go back to the joints. Each joint has to be able to move independent of its own axis. And the motion that I would say structure dictates function, but it's the function of the muscles that dictate whether or not the structure can move the way it's designed to move. So when we think of the shoulder, if we don't transfer from the superior angle of the scapula to the AC joint, then you lose the winging of the scapula and the upward rotation that is required for you to get normal glenohumeral joint motion. Well, the foot is the same way. If the talocrural joint can't move, if you lose ankle dorsiflexion, then you're losing one key component of rear foot motion. But you also have to make sure that you have motion at each one of its independent parts, which is the talocrural joint, the subtalar joint. You have to know, basically at each joint, can the talocrural joint provide motion in dorsiflexion, and can it provide the proper motion in plantar flexion? And then subtalar joint is, can the subtalar joint provide motion in pronation? So basically that plantar flexion, adduction, and eversion. Can the subtalar joint move around the axis to provide significant amounts of motion to be able to pronate? And then on the opposite side of it, can it provide the adequate amount of motion to effectively supinate? So the supination is the dorsiflexion, abduction, inversion. And so a movement around the axis, we can perform range of motion assessments that tell us, okay, yeah, we know how to test for dorsiflexion, we know how to test for plantar flexion, but are we looking at each of the independent parts? Because there's muscles that create dorsiflexion at the talocrural joint, and there's muscles that create plantar flexion at the talocrural joint. But there's also muscles that create subtalar pronation, and there's muscles that create subtalar joint supination. And then as we move to the mid-tarsal joint, you got the mid-tarsal joint, like I said, through the longitudinal axis, you'll have inversion and eversion. So there's certain muscles that cross that axis that invert the forefoot about the longitudinal axis, and there's other muscles that cross the axis that have a function to create eversion about that longitudinal axis. And then about the mid-tarsal oblique axis, you have certain muscles that are designed to dorsiflex, abduct, and evert the forefoot on the rear foot. And you also have muscles whose function, based on their attachment and how they cross the axis, whose function is to plantar flex, adduct, and invert the mid-tarsal joint, or about the oblique axis of the mid-tarsal joint. So muscles move bones, and muscles hold bones in proper alignment. And with the principles of MAT, we look at whenever you have stress, trauma, or overuse, the resultant inflammation alters the communication between the nervous system and the muscle system. So the muscles just don't fire the way they're designed to fire. And I always say it's like having loose battery cables. It's like loose battery cables. When the muscles can't fire and fire on demand, it's like there's a dimmer switch on it. They just can't contract as efficiently as they're designed to contract. And function's about timing. The muscles have to be able to contract and contract on demand. And I talked about the transformation from pronation to supination. That's all about timing. Then the gait cycle from heel strike to same side heel strike, that occurs in less than a second. So function's about timing, that the point that I actually have to pronate as I land on my left foot, I have to pronate, which places a stretch on all the muscles that eccentrically control pronation. And then as the swing leg comes through, I resupinate, and then the other leg hits the ground, and then I hit the ground with the left foot again to pronate and eccentrically control pronation to effectively supinate. All of that happens in less than a second. So function's about timing. Imagine if your muscles are sluggish and they're not contracting as efficiently. The foot hits the ground, these muscles, the muscles that are supposed to eccentrically control pronation can't do their job effectively. Body weight, you got ground reaction forces and body weight transferring through all these muscles of the lower leg and foot. And basically now all of a sudden you're in a position where you're fully pronated and the swing leg comes through and basically you're saying, well, I can't release that stored energy. That's an excessive pronator. An excessive pronator is somebody whose muscle system is weak. The ligaments and the passive structures of the foot, i.e. plantar fasciitis, or the ligaments and the passive structures of the foot take the stress when you can't effectively control pronation to move into supination and to concentrically supinate. So the biggest key to foot function, it's not that pronation is bad. Pronation is a good thing. It's half the gait cycle. Pronation is what allows you to store elastic energy so you can recoil. So if you think of the gait cycle, and you think of, pronation and supination, the gait cycle is basically like mini plyometrics. It's basically you land, you place a stretch on the muscles, and then you recoil. And plyometrics have the most effective results. The faster you go from the drop to the propulsion is the more power you're going to create. And so gait is mini plyometrics because we eccentrically control pronation to concentrically supinate. And if we're still pronating at a time when we should be supinating, as that swing leg comes through, everything comes crashing down on the foot and the muscles that support the arch and the ligaments that support that arch. And all of a sudden, those passive structures get irritated because the foot should be a mobile adapter or pronating at the time to absorb shock. But when the swing leg comes through and it's time to propel yourself forward, it needs to be a rigid lever. And the only way it can be a rigid lever if the muscles put it back in the right position at the right time. So you think about 28 bones and 55 articulations. And you just think, I mean, we're breaking it down into rear foot, forefoot relationship in the main joints. And one of the joints I haven't even talked about yet was the first ray. In the first ray, so you go through all this motion of rear foot and forefoot, and as the forefoot, as you supinate the foot, you got a motion about this first ray axis that causes plantar flexion and eversion of that first ray, which gives you medial stability on the foot. So like the peroneus longus wraps around, and its main function has a main function about that first ray axis to create medial stability on the foot, so you can propel your foot over that over the MTP joint. And so all of that has to happen at the right time. Just a weak or inhibited peroneus longus would create an inability for that first ray to maintain plantar flexion of the ground through the propulsive phase of gait. So that's an example of one muscle being weak and how it can negatively affect foot mechanics. And if you're pronating at a time you should be supinating, negative things will happen. And so function is about timing. And so if we go back to the idea of orthotics, and we have 28 bones and 55 articulations, and the rear foot and the forefoot are moving in opposite direction as you plantar flex, as the rear foot comes crashing down and in, the forefoot gets pushed up and out, and then the swing leg comes through to drive the rear foot up and out and the forefoot back down and in. Those are all dictated by muscle control. And you think of an orthotic that they put in the arch, that orthotic may block the motion. When I think about the woman that we put her in the orthotics and it took away her hip pain, but it created neck pain, all it did was redirect the stress. All it did was transfer, it took stress off of her hip, but forces have to transfer through the body. And the interesting thing is, now that I understand muscle function and doing it through the principles of MAT, is whenever you see muscle inhibition or muscle weakness, opposite muscles tighten up as a protective mechanism. So I said stress, trauma, and overuse, and the resultant inflammation alters the communication between the nervous system and the muscle system. So the muscles just can't contract as efficiently as they're designed to contract. When muscles can't contract efficiently, they can't shorten effectively. So they can't contract through their full range of motion. So if I said, okay, I'm going to just, contract my bicep. If I had an inhibition in the muscles of elbow flexion, my elbow flexors would not be able to fully contract, and it would show up as tightness in the antagonist muscles. So tight hamstrings could be weakness in the hip flexors and abdominal muscles. And so tight external rotator or internal rotators, if I'm rotating my shoulder, would be weakness in the muscles that externally rotate the humerus. And so when muscles can't contract efficiently, they can't shorten effectively. And the opposite muscles will show up as being tight. So tightness is a sign of instability. So in our assessment process with muscle activation technique, we perform range of motion assessments, not to determine what muscles are tight, but what muscles are weak. And so if I have a client that I see that they have a limitation in ankle dorsiflexion, we would conventionally say, well, they have tight calf muscles. In this perspective, it means that the opposite muscles can't contract efficiently. So the anterior tibial muscles can't fully shorten, so they can't contract effectively, which shows up as being tight calves. And until you fix the problem, until you go and address the problem, people can stretch day after day after day and stretch their calves forever. But the tightness never goes away. You never see any long-term changes in flexibility because the antagonist muscles, the anterior tibial muscles, are weak and inhibited. Until you activate those muscles and teach those muscles to fully contract, the calf muscles are going to be tight. So an MAT, our most important tool that we have as an MAT practitioner, is a range of motion assessment, not to tell us what's strong, not to tell us what's tight, but to tell us what's weak. So wherever we see a limitation in range of motion is telling us that one or more of the muscles that cross that axis are potentially weak. And then with MAT, we have the muscles or the ability to do manual muscle testing to determine which one of the muscles that cross that axis are the potentially weak. So if we take that example of a limitation in ankle dorsiflexion, we have to think, if I have a limitation in ankle dorsiflexion, we can say that's a tight calf, or we can say, what are the muscles that actually cross that axis, that are anterior to the talocrural joint axis? And those muscles are the anterior tib, which is actually two different divisions that we can test for. And then we have the extensor digitorum, which two different divisions, a lateral and medial division, the extensor hallucis, the peroneus tertius, also two different divisions. We have all of these muscles that are anterior to the talocrural joint axis, that if we see a limitation in range of motion, it means that one or more of those muscles are potentially weak. And with MAT, we have the tools to assess that. And so in that, if we see a limitation in ankle dorsiflexion, our goal is to find out which dorsiflexors are not functioning efficiently, which dorsiflexors can't contract and contract on demand. And then it's creating the understanding of what does a tight calf mean? What does a limitation in ankle dorsiflexion mean? If I have a limitation in ankle dorsiflexion, I'm testing, this is a client, a young athlete that assess range of motion and a limitation in ankle dorsiflexion. And when you check dorsiflexion, you have to lock the forefoot to the rear foot, because otherwise you'll get motion through the mid-tarsal joint, which may give you an appearance that you have more dorsiflexion, which is how the body's actually going to compensate for a limitation in ankle dorsiflexion. So in that situation, this person has a limitation in ankle dorsiflexion. So if she didn't, I would say she's at least 10 degrees plantar flex when I check her true range of motion in ankle dorsiflexion. 10 degrees plantar flex, which means that if she stands up, if she doesn't compensate when she stands up, her heel would be about 1/4 of an inch off the ground. So she's going to have to compensate through pronating at the foot just to stand up. So this is the woman trying, after she stood up. I mean, I always say posture is a position where all movement starts from. And if you start from a bad position, you can never get in a good position. So in this position with a limitation in ankle dorsiflexion, this is her trying to squat. The knee crashes down and in. When you have a limitation in ankle dorsiflexion, to truly check ankle dorsiflexion, the forefoot and the rear foot need to be locked together, because that's giving me true talocrural joint motion. If I don't lock the forefoot and the rear foot and I push up through the forefoot, see how there's motion occurring in the forefoot? Because the oblique axis of the mid-tarsal joint provides sagittal plane motion, but based on the position of the axis, for every degree of sagittal plane motion, you get transverse plane motion. So you get dorsiflexion and abduction, or plantar flexion and adduction through the oblique axis of the mid-tarsal joint. And so if you think about that, if I can't get dorsiflexion at the talocrural joint, then the next joint that provides that dorsiflexion is through the oblique axis of the mid-tarsal joint. But for every degree of dorsiflexion based on the position of the axis being oblique, I get a degree of transverse plane motion. So basically dorsiflexion and abduction come hand in hand. So if I have a limitation in the talocrural joint axis, which is dominant in sagittal plane motion, I'm going to go to the next joint to pick up that motion. So I said she'd have to pronate to stand up. That means it's going to push her foot up and out through dorsiflexion and abduction to make up for the limitation in dorsiflexion. So for her to get her heel on the ground, her forefoot had to adapt, or she had to compensate through the oblique axis of the mid-tarsal joint. So if her foot gets pushed up and out, relatively her leg comes down and in. So you watch her squat and look at how unstable that is, first off, because she's not starting from a neutral position. And you start from a bad position, you can never get into a good position. Her knee's diving down and in. That's a position. Her tibia is already internally rotated. She's dorsiflexed and abducted through the forefoot. The rear foot and the leg go together as the forefoot goes in the opposite direction. So this is a woman with a limitation in ankle dorsiflexion. Now we tested and treated all of the muscles that showed up weak, her anterior tibial muscles. After we got those muscles activated, when muscles can contract efficiently, they can shorten more effectively. And through reciprocal inhibition, muscle tightness will go away. So when you activate the anterior tibial muscles, then basically a summary of reciprocal inhibition is when a muscle contracts, it sends an inhibitory response to the antagonist muscle. So when I use the bicep as an example, when I'm contracting my bicep and trying to get full range of motion in elbow flexion, my tricep has to relax enough to allow that motion to occur. So when a muscle contracts through reciprocal inhibition, it sends an inhibitory response to the antagonist muscle. When a muscle loses its ability to contract due to stress, trauma, or overuse and the resultant inflammation, then you lose reciprocal inhibition. So now you lose the inhibitory response to the antagonist muscle, and the antagonist muscles show up as being tight. So the muscle tightness, the calf tightness, was a result of anterior tibial weakness. So we tested and treated the muscles on the anterior side of the axis, stimulated those muscles, improved the activation, or activated those muscles, where I say we tighten battery cables. Now all of a sudden the anterior muscles can fully shorten, and through reciprocal inhibition, the antagonist muscles relax. So the only way you're going to have long-term changes in flexibility is by improving the ability for the muscles that are weak and inhibited to contract effectively. When they can contract effectively, I always say it's like melting the ice. If you give your body a sense of stability, the body will give you all the mobility in the world. So after we activated her anterior tibial muscles, this is her range of motion in dorsiflexion. So now she's back to neutral. She's no longer 10 to 20 degrees plantar flex. So now she doesn't have to compensate to stand up. So in the next video, this is her afterwards. So you saw her leg starting from an internally rotated position, diving down and in when she squatted. I didn't give her any cues, because posture is a position where all movement starts from. And if you start from a bad position, you will never get in a good position. And typically that's what we think is, oh, well, if somebody's knees diving in when they squat, we need to give them cues to consciously teach them how to not let their knee dive in. Well, the structure dictates function. When that structure is on the ground and it's not it doesn't have a proper relationship with the ground, because she's starting from a pronated position, you can give all the conscious thought you can or you want, but their body, that knee, still trying to dive in. And the minute you take away the conscious mind as she leaves and walks downstairs, because she has to pronate just or excessively pronate when the foot hits the ground, her knee's just going to dive in, and you'll have more of a pronation issue. So the gait is an unconscious movement. When I said be from heel strike, the same side heel strike occurs in less than a second, you can't be thinking about holding the knee or preventing the knee from diving in. Provide the environment, and the body will, create the ability to do it properly. By activating her anterior tibial muscles, we're able to change the way she moves. So with muscle activation techniques, the idea is we want to make sure, literally, movement, I say this through the body, movement by movement, muscle by what muscle, we want to make sure that every muscle can contract effectively. And how will you know if all the muscles in the body can contract effectively? It's based on whether or not you have a limitation in range of motion. Limitations in range of motion are an indicator of muscle weakness. When muscles can contract efficiently, they can move the structure through the range that the structure dictates. So I always say structure dictates function. So structure dictates function, but it's the function of the muscles that dictate whether or not the structure can move the way it's designed to move. So the structure of the foot dictates that you should have a certain amount of talocrural joint motion, a significant amount of talocrural joint motion. The structure of the subtalar joint dictates that you should have a significant amount of motion in pronation, to keep it simple, and or supination. So plantar flexion adduction in eversion or dorsiflexion abduction and inversion. You should have a significant amount or equal amounts in each direction. The structure of the mid-tarsal joint dictates through the longitudinal axis that you should have a certain amount of inversion and eversion about that axis, and through the oblique axis that you should have a certain amount of dorsiflexion and abduction and a certain amount of plantar flexion and adduction. And so the structure dictates that those motions should occur. The axes of motion dictate that, but the function of the muscles dictate whether or not you're able to move through those ranges. So just like any other joint, if I can't move my arm into external rotation, it's because the muscles that move me there are not contracting effectively. So the antagonist muscles, the internal rotators, show up as being tight. Well, if we go through a range of motion exam and I find that, then subtalar motion, they don't pronate as well as on the left side as they do on the right side, that's telling me there's a dysfunction. That's telling me there's a muscle dysfunction, not a structural problem, a muscular problem. And I used to look at feet and look at, they have a forefoot varus or a rear foot varus. And we'd see all these, what were classified as being structural malalignments, which would dictate why somebody would need orthotics. And I actually found that these feet are in abnormal positions, not due to the structure, but due to the muscle dysfunction and the adaptation that occurs over time. Think of the feet and what we do for the feet. We've always provided, due to wall-to-wall carpeting and shoe wear and orthotics, I mean, we basically, from the knee down, where there's 50 muscles that control lower leg and foot motion, we cater to our lower leg and feet. We've provided artificial support to the muscles that support the lower leg and feet. So when we're thinking stability, we need to be thinking stability through motion. Like, can the muscles contract through their full ranges of motion to eccentrically control pronation at each joint so that they can concentrically supinate the motion about each axis at each joint? And because you have all of these individual axes, it'd be very hard to say that I'm going to put some platform underneath this foot and it's going to maximize your foot mechanics. Because if I put a platform underneath the foot, I'm taking away motion. I'm controlling motion artificially. And the interesting thing that I've seen since I've shifted over from putting people in orthotics and then understanding muscle function, and where you have a limit, where whenever you have a limitation in range of motion, it means that one or more of the muscles that cross that axis are potentially weak. Ironically, any one that I've ever seen in orthotics has a limitation in motion in one or more of the axes that I just talked about, between the rear foot and the forefoot. So as I go through my range of motion assessment, they may see a limitation in ankle dorsiflexion. I may see a limitation in a subtalar joint pronation or supination. I could see a limitation in motion in about the mid-tarsal joint, one of those axes, or even a limitation in range of motion about that first ray axis. Any one of those limitations in range of motion is an indicator that we have weaknesses in the muscles that cross those axes. And so think about that, is orthotics are typically designed to control motion because most people excessively pronate. So we're trying to control motion so they no longer excessively pronate. And this woman, when she was squatting with a limitation in ankle dorsiflexion, she had to pronate just to stand up. So compensation for her limitation in ankle dorsiflexion was to pick up that motion through the oblique axis of the mid-tarsal joint. So the rear foot pronated as the forefoot basically dorsiflexed and abducted as the rear foot plantar flexed and adduct about the subtalar and mid-tarsal joint axis. So she had to pronate in order to stand up because of a limitation in ankle dorsiflexion. Imagine if I put an orthotic in a foot underneath her foot, I would take away her ability to compensate. Because of her limitation in ankle dorsiflexion, as she tries to come forward over the fixed foot, she's trying to find that sagittal plane motion, and she can't get it at the talocrural joint, so she picks it up through the midfoot. But if you put support underneath that foot, she can no longer compensate through the oblique axis of the mid-tarsal joint, but the body's still coming forward. And now it's saying, man, I used to be able to get my motion through the midfoot, but it's not allowing me to get that motion. So that those forces are transferred all the way up the chain. They either have to turn their feet out, they turn their feet in, they lift with their hips, and they try and carry their legs because they can no longer propel forward over their MTP joint. And so if you take away I always say compensation is a good thing until you fix the problem. She needs to compensate for her limitation in ankle dorsiflexion, i.e. muscle weakness in their anterior tibial muscles. She has to compensate for that limitation in motion and the associated weaknesses. So her compensation was through the mid-tarsal oblique axis, which allowed her knee to dive in. This woman came to me because she had patellofemoral syndrome. So dysfunction in the foot was putting increased stress at her knee joint because the other end of the foot is the knee. All these muscles run up the tibia and fibula. The other end of the tibia and fibula is the knee joint. So her increased valgus stress every time she would squat or run was putting increased rotational stresses up through her knee joint that was creating patellofemoral syndrome. As soon as we corrected her limitation or basically activated her anterior tibial muscles, her patellofemoral pain was gone. So pain is an indicator something's wrong. But if you put an orthotic in underneath the foot and you take away the ability to compensate, her knee pain may go away because she would no longer have all of those rotational forces going through her knee, but something else is going to show up as being weak. Is the example of that woman where she, I took away her hip pain by putting her in orthotics, but it transferred all the way up to her neck. And then I took her out of the orthotics and the hip pain came back and her neck pain went away. And all I realized at that point in time is all I did was I didn't fix a thing. I didn't correct anything. All I did was redirect the stress. And that idea, we're only as strong as our weakest link, her next weak link got exposed because now the forces were transferring differently up her body. And now her weakness, because she still had to compensate for her instability issue or her muscle weakness issue. And so you think about that. When muscles lose the ability to contract, they lose the ability to shorten effectively, and the opposite muscles tighten up. So tightness is a protective mechanism. You think, and way back when I put MAT together, basically looked at why do muscles tighten up? When I had my fractured vertebrae, I had I tried everything. I understood the interrelationships of joints. I had orthotics, and next thing I knew, I had knee pain, patellofemoral syndrome, plantar fasciitis, SI joint dysfunction. And by the time I was 25 years old, I'm sitting there, if I'm this bad at 25, what am I going to be like when I'm 50? But I was dependent on my orthotics. The minute I put my shoes on, I got out of bed, I had to put my shoes on because I had these collapsed arches and had no stability through my lower leg and feet. And that was transferring forces all the way up through the chain. And then the orthotics were just compensatory were taking away my ability to effectively compensate. And literally, I was 25 years old thinking, what am I going to be like when I'm 50? Now, and with this idea, we have one extreme of the continuum that wants to support arches and provide artificial stability. And then we have the other end of the continuum that says barefoot training. We need to train the muscles of the feet the way they were designed to move. That's great as long as you don't have years of compensation and adaptation that need to be addressed first. I always say you got to, like with the battery, you have to jumpstart the battery, then you can drive the car. Through muscle activation techniques, if somebody is going to go from orthotics or protective shoe wear into barefoot training, that's when they're going to jump. That's like going in and bench pressing 300 pounds trying to bench press 300 pounds the first day you work out. Your muscles aren't strong enough to tolerate those forces. So the first thing we need to do is go movement by movement, muscle by muscle, get all the muscles activated, restore normal motion at each joint in the foot. Then you can transfer into barefoot training. I basically never have shoes on. I don't wear shoes when the minute I show up at the office, I take my shoes off and I work barefooted all day. And now I have arches. When I was 25 years old, my feet were flat to the ground. And it's because muscles move bones and muscles hold bones in proper alignment. And if you can improve neuromuscular function and get the muscles activated, you can actually provide an environment all the way up the chain that takes stress off of joints and tissue. If you have an instability issue, Like I said, the body tightens up as a protective mechanism. And I was saying, why do muscles tighten up? And the best analogy is when we walk on ice. The first thing we do when the body senses instability is we tighten up as a protective mechanism. So when you have stress, trauma, or overuse, and the muscles and the resultant inflammation alters that communication between the nervous system and the muscle system, those muscles just can't fire and fire on demand. That means they can't do their job to stabilize joints and protect you from injury. And so the natural neurological response, whether you're walking on ice and it's the external surface that's creating the instability issue, or if your internal system, if your muscle system is weak and it's an intrinsic mechanism that's causing instability, is the natural neurological response. This is the body will tighten up as a protective mechanism. So muscle tightness is a sign of muscle weakness. And like I said, the majority of people that I see that are in orthotics, I assess range of motion through the subtalar joint, through the midtarsal joint, through the talocrural joint, through the first ray axis, and they always have limitation in one or more of the axes that produce motion at the feet. That means there's weakness. And until you address the muscle weakness issue, you have an instability issue. And so instead of trying to artificially create stability at a joint, which would limit motion even more, I'd say we want to create motion by teaching the muscles to contract so they can move each joint about the axis these joints dictate. And you should have more motion and more mobility in the feet when the muscles are all functioning properly rather than less mobility. And the key to function is, can the muscles, are they strong enough and tolerable enough to eccentrically control pronation and concentrically create supination in a split second beyond our conscious control? Functional movement occurs beyond our conscious control. So in order for us to get from point A to point B, the body will get from point A to point B most effectively with what it has to work with. So the muscles that can contract on demand are the ones that are going to propel us forward. The ones that can't contract on demand are just along for the ride. Because in that heel strike, the same side heel strike that occurs in less than a second, if these muscles aren't all firing and fire on demand, you've lost. And then you need to seek toward outside stabilizing devices. Muscles move bones. Muscles hold bones in proper alignment with relative to lower leg and foot, and these principles carry through the whole body. Is recognizing if we can get the muscles contracting on demand, protective tightness will go away and function will improve. I think that collects our time. So hopefully that gives some insight on foot mechanics, and you can see just in a weight-bearing environment how utilizing or identifying limitation in range of motion, and say in this example, an ankle dorsiflexion correlated with weakness in anterior tibial muscles. And once we got the anterior tibial muscles activated, they can shorten more effectively and the tight muscles relaxed. And that transformation, that addressing the isolated parts, was able to carry over into weight-bearing activity. You have to break the integrated system down into its isolated parts. And with MAT, that's what we do. Movement by movement, muscle by muscle, we go through every joint, every group of muscles to determine, can these muscles contract effectively? And if they can't, we need to create the ability so they can. So those are the foundationals, the principles of MAT. And if you want more information, go to muscleactivation.com. We have all education processes that validate and support these principles. So thank you for being here. We had a good number of people that signed up for this, so thank you for taking the time, and hopefully this opens a door from our specialty in muscle function and how it relates to total body function. Thank you.